Vasantrao Pawar Medical College and Hospital and Research Center, Nashik. And our third expert is Dr. Pushkar Baviskar. He is well-known homeopathic physician from Pune and other regions of Maharashtra. So welcome all. And so now we can start with case. Dr. Sachi, please share your screen. Dr. Sachi.
Yes, ma'am. Yes, ma'am.
Yes, can you hear me, Dr. Sachi?
Yes, ma'am. Yes, sir. Can hear you.
Okay. First of all, I will introduce myself. I'm Dr. Jitendra Kodilkar, the professor in medicine, Dr. Vasantrao Pawar Medical College. So the way we are going to go forward today would be the slide would be shown and you are going to present the case. And after each side, we'll have some discussion. And the discussion would be about how to go through the case, then and how to manage the case. So we'll not waste much time. And in between, I will just stop and ask, we can discuss things. Okay?
Yes, I'm trying to share. Yeah, one second.
Okay, sir.
Okay, and then we'll discuss on history taking, how to go through history taking and your history. Okay? So after end of the each slide, we'll discuss.
Yes, sir.
Am I audible properly?
Yes, sir.
Okay.
Yes. Should I start with the lecture, sir? Or
Yeah.
Okay, so good afternoon, everyone. My name is Sachi Tinekar. Today, I'm taking an online clinical meeting on the topic neurological disorders. It is a case report of a woman with a left MCA PCA infarct with mass effect. So I should I start?
Start with history.
Yes.
So always remember, we never share the diagnosis first. We start with the history,
Yes.
and then we'll discuss the diagnosis.
Okay. So,
Yeah.
So the name of the patient XYZ, age 40-year-old female, lives in Navi Pet, Pune, dominance right-handed, occupation homemaker. Her chief complaints are difficulty in walking, difficulty in lifting and manipulation with the right hand, difficulty in speaking since 11 months. So patient was apparently all right until October 6th, 2023, when in the afternoon she fell from her bed while sleeping, and after a few hours, her daughter noticed that she was not speaking at all. She also started having weakness in her right upper limb and lower limb, for which she was taken to the hospital by her relatives. Investigations were done and showed presence of a left MCA PCA non-hemorrhagic infarct. The patient was discharged after 8 days of ICU stay. She was conscious, oriented, but had difficulty in her daily activities due to weakness of limbs on the right side of her body. She was under physiotherapy treatment, and within 2 months, she started walking indoors with the help of a cane and with maximum supervision. Currently, she's under pharmacological and physiotherapy treatment at TES Brijlal Jindal College OPD since 20th August. Her current functional status is that she's able to walk with cane indoors and outdoors with minimal supervision.
Okay. Now I will start. Whenever you take a case, you will never read like name of the patient. It should be in one go, like middle-aged female residing at XYZ place, homemaker by occupation, came with chief complaints of. The chief complaints should not be more than two. So here your weakness in your case, it is two complaints, that the weakness in upper limb and lower limb, and unable to speak, or it was just a slurring of speech. So, yes, it was.
No, she was unable to speak.
Okay, unable to speak. So, and in presenting illness, you have to describe each and every complaint in details. Like at the end of the history, as like whenever we take history, at the end of the history, we ask ourselves two questions: what is the lesion and where is the lesion? For that, the presenting complaint should be in details. So you should describe everything, like the tempo of the disease. How was the disease? Now, what do you understand by tempo of the disease? Means the patient was sleeping at night, got up, and she observed that upper limb and lower limb weakness. So you should tell me, how was the weakness? How was the progression of the weakness? So was it the weakness directly complete, and she was unable to move, that complete hemiplegia, or initially it was just weakness and that progressed to the present condition? So that is very, very important in a neurological case. You understand? It is very, very important. Then the next is the speech. If the patient is unable to speak, or she is unable to understand, so that is also very, very important. That also you should explain me in details. Why? To know the exact etiology and history. See, whenever we take a case, we never know that it is we never get investigations directly. First, on presenting complaint, at the end of the history, you should know what is the etiology, what is the etiology of the disease. So in elderly patients, the risk factors always are atherosclerosis. In this patient, she like middle-aged female, or she is on any medications that leading to type of stroke. The stroke would be like in stroke in this type, it would be like thrombotic. It can be embolic strokes. It can be bleed, or it can give some space occupying lesion. So that you have to describe in detail. So why thrombotic strokes are common? So that also we have to know why after sleeping patient gets up. So what is the reason that patient gets thrombotic stroke? Most probably here the patient has thrombotic stroke. You have not told me regarding the medication history. Was she on any medication?
So it's in the next slide. Should I go
Okay,
ahead?
so no. Wait, we'll discuss here only. So the
Yes.
tempo of the disease is very, very important. Okay, to know where is the lesion. Okay, then you have to describe, was it more in the upper limb or was it more in the lower limb? So we never post the like investigation first. Directly, we don't say that it is MCA or PCA infarct. On history, we should know. For that, we have to know if the patient has weakness more in upper limb and less in lower limb. And it is like MCA infarct. If it is more in lower limb and less in upper limb, it is PCA infarct. Here, the patient has both type of infarct, you have told already. But history should be very, very clear. So now the next complaint is like speech. So you should know what are the component of the speech to know the what type of speech it is. Is it some aphasia or it is a dysarthria? Can you tell me what is the difference between aphasia and dysarthria?
So dysarthria,
Can anybody tell
dysarthria
me
is
what is the
an
difference between aphasia and dysarthria?
So dysarthria is an impairment in speech, and aphasia is an impairment in language. So either it is a receptive language issue or it is an expressive issue. In her case, the expression of language was more of an issue.
Hello? Yeah, you're able to hear me. Hello?
Yes, sir. Yes.
Sir.
Yeah. So the difference, you should know what is aphasia and what are the component of the speech that are
Right.
also should.
Dr. Ankita, please mute yourself. Ankita Katre.
Yes. So you should know the difference between the apparatus. So what is a speech apparatus? Basically, tongue. What tongue is supplied by which nerve? Which cranial nerve? Basically, it is a hypoglossal nerve.
Yes, sir.
Yeah. And aphasias are different type of sensory aphasias and motor aphasia. In Broca's aphasia, the comprehension is lost, but comprehension is present, but fluency is lost. And in Wernicke's aphasia, the fluency is lost, but the comprehension is present. So here she has got a complete aphasia. That also difference you should tell me so that we can localize the lesion. So this helps in localize the lesion. Then the
Yes.
next point is that you have not told me any other cranial nerve is involved. That is, was there any deviation of mouth? It is very important that in this case, most probably you have missed that the patient's face was deviated to the same side or opposite side. Yes, doctor, was it present involvement of deviation of mouth here?
So deviation of mouth was not present on that day, but when we assessed her in the OPD, That's when it was present. So in my assessment ahead, I have mentioned the
Okay, so it was there. So in history only, you have to mention that the patient has deviation of mouth. So what is the cause of deviation of the mouth is the involvement of facial nerve. The involvement of the facial nerve can be upper motor neuron lesion or lower motor neuron lesion of facial palsy. In this condition, most probably it is lower mid. Do you know what is different between the upper motor neuron facial palsy and lower motor neuron facial palsy?
Yes, sir.
Yeah, can you tell me?
So in upper motor neuron facial palsy, usually the affection is on the contralateral lower side, and in ipsilateral, because the lesion is above the sense, the decussation level matters in that, and in lower motor neuron, it is affection of ipsilateral, both quadrants of the upper and lower quadrants of the face. So that's
Only basic, if you ask me, and if for understanding, if the eyes are involved, basically, if the patient, we can ask the history to the patient. Now we are in the history, so you should just ask the patient that is she able to close her eyes? If she is able to close her eyes and only the lower face is involved, then it is upper motor neuron facial palsy. And if it is ipsilateral and everything, it is lower motor neuron facial palsy. So this is very, very important to know the what type of hemiplegia is it. So it can be a dense hemiplegia to know the localization. So can you tell me what are the functions of facial nerve?
so the facial functions are the
Sensory
different
and motor.
movements, the facial expressions that we have.
Yeah. So which
That is
muscles, facial nerve supply which muscles?
the frontalis, or corrugator supercilii, orbicularis oculi, procerus, buccinator, zygomaticus major, risorius, mentalis, platysma. All of these muscles are assessed when we assess facial nerve. It's a
Yeah. And which muscles are involved for the whistling? They are
orbicularis oris.
orbicularis oris. So the word output by orbicularis oris are what? What word output are helpful in orbicularis oris and
Saying
orbicularis?
O
PB,
or
basically it is PB,
O.
P and B. So if the patient has lower motor neuron facial palsy, she would be unable to say P and B. Rest, everything, vowels and everything, she can utter it. Okay, so that history you have to tell me here in the presenting illness to know the localization of somebody is talking in between. I'm getting disturbed. Can you silence their phone? Um, please do. I request everyone, please don't talk in between, or you just message me, text me if you have any questions. Okay, here the history is there, and in the next part, whenever you present the history, there should be negative history of involvement of all cranial nerves. Doctor, can you enumerate all cranial nerves for me and others? Tell me the names of the cranial nerve.
There are 12 pairs of cranial nerves.
Yeah,
It
just
is
enumerate them and their functions.
So olfactory, optic, oculomotor. So olfactory has a function of sense of smell. Optic and oculomotor are related to eye movements and pupillary
Okay,
reflexes.
what for optic nerve, what functions are there and how you check the function of optic nerve?
For optic nerve, you check pupillary reflex, consensual light reflex, direct light reflex, and also if the patient is able to view an object in every quadrant.
Yeah, visual field also is done by optic nerve and light reflex. Then 3, 4, 6 are 3, 4, and 6 are all. What are they?
Oculomotor, trochlear,
Oculomotor. They are
and
they supply.
abducens.
They supply which muscles?
Trochlear is supplied by superior oblique muscle, and abducens is supplied by the lateral rectus muscle.
Yeah, in short form, whenever we used to learn, there was a short form LR6 SO4 rest by 3. So that means all extraocular muscles are supplied by third nerve except lateral rectus and SO4. Okay,
Yes.
SO4 is superior oblique supplied by fourth nerve. Okay,
Yes.
next cranial nerve is?
Trigeminal is the fifth cranial nerve.
Yeah, what is the function of trigeminal nerve?
It's a mixed nerve, so there is sensory function. There's a sensory component as well, and also muscles of mastication, clenching of teeth, masseter, pterygoids. All of that are also assessed.
Seventh nerve, we have discussed eighth nerve. Eight, seventh is facial nerve. Eighth is
The vestibulocochlear nerve. There are two
okay.
components. You assess balance and you assess hearing. So there
Yes.
is a Rinne's test, Weber's test, and also equilibrium test.
Yes. The next is ninth cranial nerve. So
That
ninth
is
cranial nerve is
glossopharyngeal nerve.
what are the functions of ninth cranial nerve?
So you check the sensations on the tongue,
Hmm.
2/3 of the tongue, and also tongue sensations of the tongue. It's a sensory nerve.
Okay. Then next is
Vagus nerve.
yes.
For that, you assess the uvula position and gag reflex.
Okay. Then
And 11th is spinal accessory nerve,
yes. Good.
and that is, you assess that by assessing your muscles, trapezius and sternocleidomastoid.
Okay.
You are supposed to shrug the shoulders and move left to right.
Okay.
The last is hypoglossal nerve,
Okay.
for which you assess tongue movements. You ask the patient to protrude the tongue outside and you check the movements left to right and everything.
Okay. Why the
And even
cranial
inside.
nerves are important is for the localization of, again, why the cranial nerve examination is very, very important to know the localization of the lesion. So how they originate. So the first three cranial nerves originate in midbrain, next three are in pons, and rest are in medulla. So
Yeah.
this, if the involvement of any cranial nerves help us to know the localization of the lesion. Like CNS is like mathematics. So you know the different, you analyze the cranial nerves and you get the localization of the lesion. So that is very, very important to know the cranial nerve, their functions. Good, you know everything. That is very, very good. Then my next question is why this is an thrombotic stroke? Why after patients gets the why this patient is having the thrombotic stroke? Can you tell me?
So usually hemorrhagic stroke have a faster progression. This patient had a
Good.
slower progression. It
Yes.
started with weakness and affection in speech, but she was still able to go by herself to the hospital. Like she was taken by her relatives, but she was not unconscious or vomiting or had severe headaches. So the progression was gradual. So that is an indication of an embolic stroke. Or thrombotic.
Embolic, most probably thrombotic. We say
Thrombotic.
here thrombotic due to atherosclerosis or thrombotic stroke. Why there are why we say thrombosis? Can you tell me, doctor, how the thrombosis formed in the blood?
So in her case, she was on a
Not in her
medication.
case. In general, I'm asking how a thrombosis
Sometimes
form in
with
the blood.
the blood circulation in the brain, sometimes there is an
Not
interruption either
brain.
due to
In any vessel. In any vessel.
either due to
Why there is a thrombosis?
lipid accumulation or
Uh,
hypertension or all of these
Not lipid up. No. So there is a always of a good flow, and if there is a turbulent flow, there is atherosclerosis. There would be platelet aggregation, and then it leads to thrombus formation. But why at night patients get this thrombosis? It can happen at any time, but why thrombosis occurs at night only? Can you tell me? What are the factors present in the blood which helps for the blood not to clot? It is a simpler way of asking. So tell me, what are the clotting factors and what are the inhibitors of that? So what is there in the blood which, do you know what is coagulation cascade?
yes, sir.
Yeah, can you just in short for everyone's understanding, what is there in the blood that helps
These
not to clot?
there are
And
these
what
clotting
helps?
factors. There are
Yeah,
these
clotting factors are there. Yes, can you just enumerate?
factors 1 to 12 are present, which help to keep the blood flowing and so that coagulation doesn't happen.
Yes, what else? Okay, there is a cascade. What is there in other factor that is antithrombin 3 and plasminogen activator is there? Plasminogen activator is present in the blood that helps that the blood not to clot. But what happens at by the age and at the night and at the night at least flow sometimes may get turbulent and there is a plasminogen activator inhibitor. It is secreted.
Yes.
So there can be a thrombosis. Okay. And what are the other things in the blood vessels that lead to thrombosis is endothelial damage. Endothelial by age, hypertension, atherosclerosis, there is an endothelial damage. So that is very, very important. Other cause to lead the thrombosis in the patient. And other is embolism. Embolism may be due in after some time we'll discuss that why there is an embolism. It can be in valvular heart disease. If there is in valvular heart disease, we get atrial fibrillation and can lead to thrombus and embolism. That is in MS case. In this case, we don't have, but you should know regarding this clotting factor and plasminogen activator inhibitor is very, very important. Okay.
Yes.
Yeah, am I not very fast? So it is easy to understand, and everybody is getting this. So am I not fast? Are you? Everyone is able to hear me and understand. If you have a problem, please stop me. I can discuss it again, and you can. If anybody has questions at the end of this discussion, we can discuss this. Okay. Come to the next slide.
So her past medical surgical history is none. Her drug history, she was
Family history is very, very important because we should know the familial causes of familial hemiplegic syndromes which run. Can you tell me one syndrome or one factor which run in the family which lead to thromboembolism and hemiplegia?
so ALS sometimes has a familial
No,
factor.
not ALS. Any other disease, autosomal dominant diseases.
DMD can be.
No no BMD, no. Any other disease which can lead to runs in family, or it is like factor S deficiency, hyperhomocystinemia runs in family, Fabry's disease, polycystic
Vitamin
kidney
B12,
disease run in
vitamin B,
family. So these are the
hormones.
2, 3 diseases which run in families, which can lead to familial stroke syndrome. Okay. And other drug history. So can you tell me which drugs leads to thrombosis embolism?
So ecosprin 75 is very commonly, I have seen that in a lot
It
of
leads to
patients.
bleed. It leads to bleed. I'm asking thrombosis and embolism. Ecosprin is antiplatelet drug. So that is antiplatelet drug. But we have to know what leads to thrombosis. Commonly in females, it is OC pills, oral contraceptive pills
Oral
can lead to,
contraceptive.
yeah, what else? Others? Any antibiotic, anything? Okay, fine, leave it. So go to the history. Yes, read.
So drug history, tab Levas 40, tab Ecosprin 75, tab Peranulin, tab Neurowire, and investigations, MRI of the brain. The impression was acute non-hemorrhagic infarct of left MCA-PCA territory with mass effect and gliotic changes in the left posterior temporal region. A physical examination on observation, build endomorphic, pallor, edema, lymphadenopathy, icterus, cyanosis, clubbing, erythema, eruptions absent.
Okay. So first, always it is a general examination. First, investigation comes at the end of the all slides. Never put investigation earlier. So we'll discuss in detail everything. The first, so pallor for us is the patient. For us, patient is conscious, cooperative, higher function basically. Patient conscious, cooperative, well oriented with time, place, person. So everything you have to ask, and then we start with pallor. Anemia, pallor for anemia. Then if the patient has edema due to any cause, then
Sir,
don't change the slide. Don't change the slide. Or you have done the examination.
yes, sir, it's ahead. It's
Okay, so we'll discuss first, and then pulse and BP. Can you tell me, can you define pulse and tell me different character?
sir. We check the pulse at the radial artery.
Yes, good.
And we
What
check
you see in the pulse?
the
Pulse is very, very important. So we take pulse by 3 fingers. What are the importance of 3 fingers?
Sir, you check the rate of the pulse with one finger, you obliterate any other flow by the other finger, and you check the
Yes.
volume of the elastic uplift with the other the
Yeah,
middle.
elasticity. We palpate the pulse to help if there you can see some hardness, atherosclerotic type, or what is the type of the character of the pulse. So can you tell me different type character of the pulse?
So it can be a thready pulse, it can be a
It is anacrotic pulse, dicrotic pulse, pulsus Bisperians, pulsus parvus a tardus, and pulsus paradoxicus. Doctor, can you tell me what is pulsus paradoxicus?
uh, so there is a
Other students can also help us. It should be interactive. Yeah. Continue,
Yeah,
please.
yeah. Pulsus. What is pulsus paradoxicus?
there's an imbalance between the pulse, like the circulation of the heart
No,
rate.
no, no. It is not like that. There is a 10 mm fall in the BP during inspiration. It is a misnomer. Pulsus paradoxicus is a misnomer that there is a fall in BP. If it is more than 10 mm of Hg fall during inspiration, it is pulsus paradoxicus. Okay. Then comes clubbing. Can you tell me what is clubbing? Very, very important clubbing.
So
And it would be the examiner's favorite question always. So can you define clubbing?
So clubbing is there is an obliteration of the levy bond angle. We check it with the
See,
standard
Doctor, remember,
scale.
whenever an examiner asks you pulse, so he's interested, not remix, he's always interested what is there in the books. So it is bulbous enlargement of the soft part of the terminal phalanges with longitudinal curving of the nail bed.
Yes.
And what are the grades of the clubbing?
So there are 4 grades, and at the end there is a parrot sign. So the enlargement is so much that it resembles a parrot.
So the first grade is softening of the nail bed. Second is obliteration of the angle of the nail bed.
Bond angle.
Third is paradic appearance. And the fourth is hypertrophic osteoarthropathy. It is the grade 4 clubbing is X-ray finding. Okay, why clubbing is important? To know if the patient has any valvular heart disease, cyanotic or cyanotic heart disease. Doctor, can you tell me why patients get clubbing? Any theories behind clubbing? Can you tell me any theory? Or what are the causes of clubbing?
So because of, like, in stroke and conditions, there is impaired circulation, and so
No, there is an hypoxic
digits.
therapy, therapy, sorry. It is hypoxic theory and platelet-derived growth factor theory, which leads to clubbing. Can you tell
Yes,
me
there
what
is
are the different
low.
causes of clubbing?
There are
The
low blood
respiratory,
oxygen
it
levels.
is respiratory cause, it is cardiovascular causes, then abdominal causes, and endocrine causes. So, what are the respiratory causes? Is any respiratory
Because of
disease
any
which leads to
pulmonary
clubbing?
fibrosis or bronchiectasis,
Yes,
something
good.
you can see.
Then in cardiovascular,
So it can be a congenital defect can
good.
cause.
Yes, then
Can be liver
abdominal causes.
disorders. There is any renal dysfunction that can also cause.
Yeah, what is the abdominal causes of it is Crohn's disease and ulcerative colitis, endocrine causes,
Uh, any pancreatic insufficiency,
so
any
pancreatic and thyroid insufficiencies.
thyroid
Okay,
insufficiency.
yeah. So this is lead clubbing. Clubbing is very, very important for our students because it is the next icterus that we'll not discuss because it is not irrelevant to this case. But blood pressure. Blood pressure is very, very important. Doctor, can you tell me how you take blood pressure? Oh, sorry. And one more thing in pulse, how you describe a pulse. The pulse is described like rate, rhythm, volume,
Rate, rhythm, quality,
tension.
and volume.
Yeah, so I will just summarize it. Rate, rhythm, volume, tension, force, equality, radio-radial delay, and radio-femoral delay is very, very important. So can you tell me the causes of irregularly irregular pulse and regularly irregular pulse? Causes of irregular pulse. That is atrial
Uh,
fibrillation.
yes.
Regularly irregular.
Regularly irregular could be so any coronary artery disease or any
The heart
heart
blocks.
failure.
It is second degree
Heart.
heart block. Okay.
Yes.
Okay. So that is very irregularly irregular. Atrial fibrillation, very important for formation of the thrombus. So it is so pulse is very important. If the patient has pulse, irregularly irregular pulse, it is air, and you directly come to the diagnosis. Okay. So we finished everything: pulse, BP, sinus, and blood pressures. Yes, doctor. Tell me what is importance of blood pressure? How you take blood pressure?
So you can take it either in the conventional method with the sphygmomanometer, or nowadays there's an Omron digital
No,
method.
no digital. We always use mercury and sphygmomanometer. Yes, tell me how you take that PP.
So you place the place the strap on the patient's arm, and then you raise the pressure. You take it above 140, 160. Then you, with the stethoscope, you measure the brachial artery pulsations, and that's how you. So you start with, you take it up above 120, 140, and the pulse has to be obliterated. And after that, when you lower, when you hear the pulse again, that's when you that's how you check the BP. And sometimes you hear some other sounds as well. They are Karatkov sounds that can also be heard.
Yeah, good. Yeah, good. So
Sir,
come to the
sorry
next slide.
to interrupt,
Yeah,
sir. Sir, can we run little bit fast because we have time?
yeah. Okay. Yeah. So next, change the slide. Next, come to the examination, CNS examination. Yes.
CNS
So
exam.
yeah.
I should change the slide.
No, just start with the CNS examination. Yes.
Yes, sir. So the
Yes.
higher function examination. So the
Yes.
patient orientation, date was intact, time she was oriented, person well oriented, she was well oriented. Short-term memory recall was possible after cues. Long-term memory was present. Speech affected transcortical motor aphasia. Cranial nerves, all cranial nerves were intact except facial nerve. Facial nerve was affected. The muscles were procerus, buccinator, rhizorius, zygomaticus major, and platysma were affected.
Yes, we have discussed cranial nerves. So can you go to the next slide?
Yes, sir. The tone. So the tone was assessed using the modified
Before tone,
Ashes.
can you define what is tone? Definition of tone?
So the passive resistance to movement that we get from.
Okay. Can you tell me different types of tone?
So there can be hypertonia, that is spasticity and rigidity. Then there is hypotonia, and there's also flaccidity, which is
Before
no
this,
tone.
can you just tell me in what type you find tone you find in in this condition?
So in this condition, she had hypertonia. She had spasticity.
Okay, hypertonia. So that is a classical feature of UMN type of lesion, upper motor neuron type of lesion. Okay, just tell me your findings.
So in her case, the most affected components were shoulder extensors. Her tone was 1 plus. Elbow flexors was 1. Elbow extensors was 2. Wrist flexors was 1, and wrist extensors was 0. And her upper extremities were more affected than lower extremities. Her clonus was present at the ankle plantar flexors and dorsiflexors. That was affected. And the rest was normal.
So me whenever okay, tone is yes. Why clonus was there? It is like very difficult. It is a finding of element type of lesion. So why clonus?
So
Clonus is
the clonus are of two types, ankle clonus and patellar clonus. So in
yeah.
ankle clonus, it is usually a pyramidal lesion above S1. So
But it is there in the spinal cord lesion. In hemiplegic, we rarely get clonus. So take fine, but you got the finding. But I don't think you never see clonus in like UMN type of lesion. So it is like a lesion in spinal cord. So eliminate, just don't say clonus. Okay, then next you come to the power.
yes, so strength is. So in her case, we checked the voluntary control. So she was. So it was shoulder joint 1 going towards 2, elbow joint and wrist flexors was 1. So, as you said, power. So she was like in a pattern. She was in a synergy pattern.
So can you tell me grades of power?
So, sir, in her case, because her right upper extremity was affected, we took voluntary control. So the grades of voluntary control are
Grades
there is
need
one
just grades of power.
overall. Okay, so
How you see the power, grades of power. So first is
there is no movement, and next is
okay.
flicker of movement,
Yeah, flicker movement, yes.
and next is
Then
gravity
eliminating
movement,
gravity, yes.
eliminating gravity.
Eliminating gravity. Then
Movement
grade 3,
without resistance against gravity is possible.
yeah,
Then
with
movement
some
against gravity is
resistance
possible.
and normal power.
Yes.
Yes. Okay. So here she had grade
So, sir,
3, grade 2 power.
yes, a grade 2 power.
Okay. So okay, go ahead.
So, outcome measures. So, we took some physiotherapy outcome measures. So, we assessed her cognition with mini mental state examination, and then her components of how she is in supine, sitting, and
So
standing position.
what are the different components of mini mental scale?
So, we check orientation, registration, attention, calculation, recall, language, and praxis. We check these components and how
Hmm.
she fares if she gets a
What are
score
the
of
point
20.
distribution of orientation, registration, recall, memory, and language? So it is out
So,
of 30. Yes.
yes, sir. So each component, so sometimes if there are three questions in one, then there's a score of 3, or others are scored in as 1, 1, 1, and at the end you get a score out of 30. 26 and above is normal. Below 26, you can classify it as impairment.
Okay, fine. Go ahead.
So then we took a stroke rehabilitation assessment of movement stream scale. So it has different components of supine, sitting, and standing activities. So in her case, the most affected components were she couldn't place her hand on the sacrum, she couldn't open a fully closed fist or close a fully open fist, and thumb opposition was not possible. So the interpretation is as moderate affection and voluntary movement and basic mobility. Then we took a timed up and go test, which is to check her gait speed and her agility. And that total score was 24.7. The normal score is usually 13.5 seconds. In that score, she should be able to complete the round. So the interpretation is the person has walking and balance issues. She needs a walking aid to go outside in a supervised environment. Should I go ahead?
Yeah, go ahead.
Then we took a mini BEST scale, that is balance evaluation system scale. It is a scale that assesses dynamic balance as well as static balance, reactive and proactive balance as well. So there were different components: anticipatory, reactive postural control, sensory orientation, and dynamic gait. In her case, the most affected components were response to perturbations, reach outs, and pivot turns during walking. The score was 11 on 28, which was very severe affection and balance. For speech, we took a Mississippi aphasia screening test, mass scale. So, like I said, she had transcortical motor aphasia. So, she had difficulty in initiating conversations. She was able to do repetition and she was able to understand. Comprehension was intact, verbal fluency was a problem, and repetition was intact. So, the problem was in initiating conversation or naming something. That was a problem. So, in her case, affected components were naming, automatic speech, verbal fluency, and writing. So the interpretation was she had a severe affection of speech with expression of speech more affected than comprehension or reception. Then we took a Barthel index, which is an activity of daily living scale. And in that, her score was 85 on 100, which is moderate dependency, like how dependent she is on someone else to do her daily work. So the most affected components were grooming, stair climbing, and dressing.
Okay.
So then the differential diagnosis would be transient ischemic attack.
Yeah.
Subdural
Can you
hemorrhage.
define what is TIA?
Sir, after neurological insult, when the surviving neurons, the supply to them is reducing. If they are at the ischemic penumbra, then they are revived after a while. They are still viable. They are still functionally viable. Less than
So
if, the progression is less than 24 hours. If the patient revives within 24 hours, then we say it's a transient, like short-term situation. So it's a transient ischemic attack.
So how is the deficit here? What is the type of deficit?
It's an embolic deficit.
No, it is a focal neurological deficit. So the
Focal
definition of transient ischemic attack is focal neurological deficit which recovers within 24 hours. So that
Yes.
is TI. And what is RINDS, RINDS? Can you tell me? Anybody? RINDS, RINDS. Okay, it is reversible ischemic neurological deficit. So it is defined as focal neurological deficit which recovers within 7 days of the onset is known as reversible ischemic neurological deficit. And it is the examiner's favorite question again. So you should know what is RIMS, reversible ischemic neurological deficit.
Yes, sir.
Okay.
Then
Yes, go ahead.
subdural hematoma, there is cerebral neoplasm, cerebral
So how you
encephalitis.
differentiate a stroke, like ischemic stroke, and if it is a hematoma or bleed? So or neoplasm. So how you in general, just how you distinguish?
Sir, subdural hematoma, there would be like in the scans,
On
MRI,
history, on
CT
just on
scan.
history, on just on history. We have
Subdural.
discussed this earlier. We have discussed just if the patient's tempo is that patient is sleeping, gets up in the morning, and patient has hemiplegia, it is generally a ischemic stroke. Patient is working, patient gets thunderclap headache, and patient is unconscious. Then it is a bleed or hematoma, or sometimes convulsions. If the patient does convulsions and focal neurological deficit, it is bleed. So can you tell me, doctor, what is Todd's palsy?
Todd's palsy.
Is again examiner's favorite question. It is focal neurological deficits after conversion. That is Todd's palsy. Okay, so go ahead. And neoplasm, though, what are the classical history that patient will give you in a patient of neoplasm? How they present? It would be this type of patients are always older age patients.
Yes, weight
They
loss.
give history of weight loss history. It should be
Yes.
more than 10%
Appetite.
of the 10% of the body
Cachexia.
weight, loss of appetite, and very important, they present with seizure disorder. Okay. Then infective etiology, it is like meningitis. You get hemiplegia in meningitis, that is infections. So therefore that the patient gives history of any infection.
Fever and yes.
Yeah, fever. It is very, very important that patient has fever, and in examination you get neck stiffness. So that is uh, uh, the due to infections. Okay. Then how you go to how you go to the investigation. So what is the most important investigation if the patient comes to you, and patient comes to you? What is the most important investigation you
So the most immediate one that is
will
done
do?
is CT. CT scan is done immediately, and then the patient is also sent for an MRI if it's
Yeah. Why we do
significant.
CT, and what is the importance of MRI?
So in MRI, we are able to, because of the magnetic resonance, we're able to identify which area we can localize the lesion
The
area.
localization on history also is very important. This first we do CT. So first understand that CT is done. We just do CT to eliminate bleed,
Yes.
and
And to
we do
differentiate if
MRI.
it is hemorrhagic
Yeah,
or
yeah. So that's it. And then we do MRI. If it is the patient presents within 6 hours of the onset of the symptoms, we can thrombolize the patient with tissue plasminogen activator. That is very helpful. That is in MRI, we do diffusion weighted cuts we take, and that is very helpful to know it is an acute onset infarct. So if it is the patient present within 4 to 5 hours, we can thrombolize the patient. So that is very, very important. So doctor, can you tell me what are the criteria for the thrombolysis? If the patient present within 6 hours or 4 hours, what are the criteria, or what are the indication and what are the contraindication for thrombolysis? So what are the contraindication of thrombolysis? in hemiplegia? It's some,
The patient has hemorrhage. If it's an
yeah.
ongoing hemorrhage.
No, we never thrombolize in patients with whenever it is like it is bleed, we never thrombolize. But what is that? What this criteria is, the BP should be less than 180, and if it is more than 180, we don't thrombolize the patient. Then again, if the patient has got a recent surgery or patient has some bleeding disorder, we never thrombolize the patient. So that is very, very important. But if you get excellent result, I have treated many patients uh, who were presented within 4 to 5 hours of the 4 to 5 hours of their presentation of the symptoms, and we treated with the thrombolysis, and there was a complete recovery of focal neurological deficit.
Yes.
Okay, and others investigation like lipid profile, thyroid, we do. Then BTCT, PTINR, we should do if the patient has got any patient has any bleeding disorder or lipid insufficiencies. Thyroid disorder also can lead to stroke. Then very, very important, diabetes is very common in India. Diabetes can lead to atherosclerosis, and it can also lead to thrombosis and embolism. Doctor, can you tell me what are the stroke mimics?
Uh,
CVA, cerebrovascular accident, hemiplegia, in other disease, like what are the stroke mimics? And we can treat the patient and patient is fine. Stroke mimics
there is
are,
some hemiplegic migraine is also
yeah,
there.
good, excellent. One, migraine. Then there is
Uh,
hypoglycemia. Then electrolyte imbalances, hypoglycemia and hyperglycemia both can lead to hemiplegia. Then
tumors can lead to.
any metabolic insufficiencies like hyponatremia, and metabolic insufficiencies can also lead to this. So that is are the stroke mimics.
Yes, sir.
Very, very important to know. You can treatable causes and you can treat them.
Yes, sir.
Okay. Then go ahead. This is the last slide. No.
So this is the treatment interventions of
Treatment part. Yes. Yeah.
physiotherapy.
You just read what treatment you have given.
So if in her case, her upper limb was more affected. So for upper limb movement initiation at wrist joint, we give an approach called Brunstrom approach for movement facilitation. So usually after a lesion, the reflexes that have been integrated in childhood, they appear again as pathological reflexes. So this method is a way in which you can, with the use of pathological reflexes, for a while, you can initiate movement in the affected hand. It also has a connection with mirror neurons. So this approach is used. It is a slightly conventional approach. The next is an advanced approach of neuromuscular electrical stimulation for wrist extensors. So while the hand is stationary, the electrical stimulation is applied, and with the electric current, the movement, voluntary movement, is made to happen. Then there is a motor relearning program where you divide the task into different components. So we first analyze the task, then we look for a missing component, and then we practice that component. And so slowly and steadily, the person gets a grasp of it. So for her, reaching and grasping object in affected hand. Then next is a controlled step up and step down movement from a stepper. So there is a neurodevelopmental technique or NDT technique. So this says that we should focus more on tone influencing patterns and normal patterns of movement and avoid abnormal patterns. There are key points of control. There is a guiding hand and there is an assisting hand. So the therapist stands behind the patient, and with the help of the guiding hand, the hip and knee flexion is facilitated. Then there is functional electrical stimulation as well. In functional electrical stimulation, the patient is performing the movement and the electrical stimulation is also going on. So in her case, we can use it for ankle dorsiflexors. We can even use it for everters, because many a times in stroke patients, the inversion we see more than eversion. In balance training, we can make her stand in eyes open, eyes closed position on various surfaces. We can give her weight shifts, and so that we can make her shift more towards the unaffected side. Uh, because many of the times patients do shift to the affected side if it's a pusher syndrome or in other cases. Then there's a balance master approach. It's a relatively newer equipment where a patient stands and with the help of a harness and on a foam surface or a stable surface, the values are seen on a computer, and with that you can assess the sway, velocity and center of pressure, and you can also, there are values, so you can understand how much of sway is going on. Digital values are there. Objectives, it is more of an objective measure of balance. Then there is gait training, where you can do obstacle walking with cones placed on level surface, walking with head turns. Then there's dual tasking, one task as sometimes counting or saying numbers in reverse or some kind of subtraction or addition, and pivot turns. Then there is something called body weight supported treadmill training, where on a treadmill the patient stands with a harness and she's made to walk. There are also, along with this, there are virtual reality or games, exer games, which are exercise games which are used so that the movement is facilitated. So these are the different interventions that we give in physiotherapy.
Okay, good. So we are running short of time. For last 5 minutes, we'll discuss things or we'll take questions. So if anybody have any questions, you can ask me directly. Unmute yourself and you can ask directly.
Okay, so, sir, we will discuss it later after Ayurveda and homeopathy opinion.
Okay.
So here, thank you so much, Sachi. Very detailed and nice presentation. And you have given surprise viva. And from one side, it is 100 out of 100. Right, sir?
Yeah, it's good. Excellent presentation.
So next is Dr. Narayan Jadhav. He is member of Board of Ethics and Registration from National Council of Indian Medicines, Indian Systems of Medicine, Ministry of Ayush, from Government of India, New Delhi. So he is basically Ayurveda practitioner and he is from medicine, Kai Chikitsa subject. So, and he has treated many cases. He has treated many cases of cerebrovascular accident, and his research is on it. So, we invited him for his expert opinion. So, please. So, unmute yourself.
Yeah. Namaskar. Good evening, all of you. First of all, I would like to congratulate the Department of Ayush, Maharashtra University of Health Sciences, to taking such a interdisciplinary clinical meeting and providing the platform to young researchers. I would like to congratulate Madam Dr. Gitanjali Karle Madam and your team also. Being a ex-faculty of this MHS, I'm very much happy to taking this initiative by you because if you are talking about this disease case, I would like to even congratulate. I don't know the faculty's name, Doctor. I think
Dr. Sachi is
Yes, Dr. Sachi. Yes, yes, sir.
okay,
from
Dr. Sachi,
and
and
then Dr. Jitendra Kodilkar. He is
and Dr. Kotilkar ji.
Kodilkar.
Nice discussion. I have gone through your discussion also. But I per time constraint, I would like to focus on only the treatment aspect of this disease only, please. Only treatment aspect I want to discuss. I want to share my thoughts about it only. Uh, as per Ayurveda concern, being a Ayurvedic physician, and yeah, in Ayurveda, this disease comes under the Vata Vyadhi. If the Ayurvedic persons are here, they will well know the terminology. But the other faculties may not aware about this terminology. But in Ayurveda, at that time, this disease is explained in Sanskrit language. I would like to quote only this Gritvat Ardham Tanor Vayu Siras Nayur Vishoshcham Paksham Anyantaram Hanti Sandibandhan Mokshayam Krusma Ardha Kayastasya Shadakarmano Vichetanam Ekanga Rogam Takechid Anyam Pakshvadam Vidu. अभी जो डिस्कशन हुआ, अभी जो जो रिसर्चर ने जो भी बात बताई कि ये एक हेमीप्लेजिया की केस है, और इसका लास्ट डायग्नोसिस उन्होंने बताया कि नॉन हेमोरोजिक infarct with mass effect. At that time, our acharyas have told this diagnosis. It's a when there is no facility of MRI, CT scan, or any diagnostic tools, they have gone through the only clinical sign and symptoms and described this disease, and not only the pathophysiology of the disease, but the treatment aspect of the disease is described by them only. When we going towards the treatment of the disease, I think we all know the panchakarma therapies. Panchakarma therapy, these are the biopurificatory therapies of Ayurveda, very specialized treatments, particularly in this cardiovascular accident. Mainly, it is a infarct, what we call in our symptomatic pathophysiology. There are 4 types of what we call the pathogenesis. अतिप्रवर्ती संगोवा शिरानाम ग्रंथियो अपि च विमार्ग गमनम चापि स्रोतसाम दुष्टि लक्षण. There are only 4 type of lesions, what we call atipravarti. Excess, it may be secretion, it may be absorption, it may be uh, what we call production. Second one is a sanga, obstruction, obstructive pathology should be there. Third one is vimarga gamanam. It means here is a vascular accident. Cerebrovascular, maybe cerebrovascular, cardiovascular, or renovascular accident. Vimarga gamanam. These are the 4 main pathological symptoms of this disease. Now comes towards the treatment aspect. In Pakshavada, if we going to the basic principles of this Pakshavada, Pakshaghat, it means Ardhanga treatment aspect, Svedanam Sneha Sanyuktam Pakshaghate Virechana. When we particularly when going towards the what were the treatment of neurodegenerative treatments, there is a very important treatment in this concept, Mastishkya, Sirodhara, Sirobasti, Siropichu, Siroabhyanga. It particularly Sirodhara or Sirobasti, it is medicated oil retention therapy on the head. Medicated oil pouring continuously to the within a particular volume from particular height. It pacifies the vata dosha, and also it is a vibrational therapy. In if you see in the pathogenesis of this infarct, when there is a circulatory disturbances are there, in this particular treatment, the vibrational therapy, it enhances the circulation, it enhances the dilatation of that micro circulation. The second treatment is a Nashya Karma, nasal insufflation. The medicated oil power in the nasal insufflation by nasal route only. The procedure stimulates vital centers in the brain, clears the channels by draining mucosal secretions and removes congestion, which result in improving cerebral circulation, nourishing the nervous tissue, corrects the neurovascular anomalies, and improves the sensory perception. There may be the possibility of direct entry of nasal medicines in CSF, in particularly in Ayurveda, Mastulunga, the term is quoted here, the possible transaxonal transportation, secondary effect of olfactory stimulations, like neuromonal effect, entry to the intracranial space through spatial venal anastomosis. This particularly, I have used the Panchendriya Vardhantel Nasya Karma in most of the uh, cases of the paralysis or cardiovascular accidents, especially in the hemorrhagic infarct. Sorry, non-hemorrhagic infarct. Most important therapy is a Basti therapy. We usually use Basti therapy. It is nothing but the medicated enema. Medicated enema, it especially Madhutelic Basti. I have used Madhutelic Basti. The ingredients of the Madhutelic Basti are Madhu honey in equal proportion with the oil, til oil, plus some medicines prepared with very scientific manner. The homogeneous mixture prepared with and it is given through the rectal route. It improves muscle power in paralysis patients. It may be due to the decrease in cerebral edema. The hypothesis is there only. After that, we routinely use some Keralian therapies in these particular cases. One is a Pizincial. It is nothing but dhara, tail dhara throughout whole body. The oil is medicated oil is powering through the whole body. Lukewarm oil powered through the whole body. 4 massagists are required for this treatment. Simultaneous massage and what we call the sudation or steam simultaneously. Sneha and Swedana is going on with same period and same time. Second treatment is Patra Pottali Swed. There are so many medicated leaves having properties to build the muscles, to strengthen the muscles. Have take into the one pan and we have to hitting them and prepare a pottery, one bonus, and then simultaneous massage with medicated oil and giving heat to the patient with a specific manner. That is a patra pottali way. It enhances the muscle power, it enhances the muscle tone, and it enhances the what we call the difficulties in the difficulties in the walking or grip muscle power. It improves the muscle power also. These are the some sort of therapies. I would like to uh, such a cases in Ayurveda. Vat Vyadhis or these neurodegenerative diseases are fall under Asto Mahagada. The group of 8 diseases, those are very most difficult to manage it. These are the Asto Mahagada. All our Acharya, Charak, Susrut and Bhagvatacharya have classified this particular disease group of diseases in Asto Mahagada. Difficulties, diseases, difficult to manage it. And these particular diseases are managed by these therapies. I want to request all of you because such type of diseases are not only treated by only one pathy. It may be modern pathy, it may be Ayurvedic, it may be homeopathy. We need a team of the experts. I think this is the motto of this Maharashtra University of Health Sciences to organizing such a platform. I would like to congratulate our Honorable Vice Chancellor, Madam Dr. Kanitkar, Madam, Pro Vice Chancellor Dr. Nikum Sir, and Dr. Gitanjali, Madam, uh, for such a providing such a nice platform for interdisciplinary and integrative medicine. Because now the era of integrative medicine only, we have to manage all these critical cases by modern medicine, diagnosed with modern criteria, and shift over to the all these potential therapies. It may be from homeopathy, it may be from Ayurveda, it may be it needs, especially these cases needs the physiotherapy. When we look into these Ayurvedic therapies, especially Keralian therapies and all the Abhyanga massage therapies, it is nothing but the medicated physiotherapies. Most of the external therapies, I would like to term them quite the medicated physiotherapies only, because these cases needs rehabilitation. These cases needs rehabilitation. So we have to treat by these therapies only, multiple therapies, those required. We have to diagnose with all these team. I would like to put one example here. Nimhans, I think we all know, in Nimhans, they have opened one integrative department for particularly these cases, neurological, it may be psychiatric and neurological cases, diagnosed by and treated by all these teams: Ayurvedic physician, modern physician, dietitian, physiotherapist, yoga specialist, even uh, even
Homeopath also, sir.
homeopath also. Uh, Hence, I would like to again congratulate, and I would like to thankful to Dr. Gitanjali madam for inviting me for and providing such a nice discussion and such a nice presentation. Thank you very much.
तुम्ही जसं म्हटलात तसं बरोबर आहे. आपल्या या ऑनलाईन क्लिनिकल मीटिंगचा उद्देशच हा आहे की सगळ्या पॅथीचे स्टुडंट्स इथे जॉईन आहेत, फ्रॉम मॉडर्न
Yes,
मेडिसिन,
yes, yes, yes.
नर्सिंग, फिजिओथेरपी, युनानी,
Hmm.
सगळे स्टुडंट्स इथे आहेत. आणि सगळ्यांना आपल्याला माहिती पाहिजे की कुठल्या पॅथीमध्ये काय चांगलं आहे आणि कुठली केस
Then.
रेफर केली गेली पाहिजे. एक
Yes,
वेळ
yes, yes.
आपण जे आयुर्वेद आणि होमिओपॅथ ह्या ज्या सिस्टीम्स आहेत यांना तरी मॉडर्न मेडिसिन विषयी बऱ्यापैकी माहिती असते, कारण आपल्या
Yes,
सिलेबस.
yes, 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 yes. Ah,
पण मॉडर्न मेडिसिनचे जे डॉक्टर्स आहेत त्यांना आयुर्वेद, होमिओपॅथ, युनानी याविषयी
yes,
अजिबात
yes.
माहिती नाहीये. तर त्यांना
Big.
या गोष्टींची आयडिया येते की काही केसेसमध्ये पॅरलली जर गेलो तर त्या चांगल्या रिझल्ट देऊ शकतात. काही लिमिटेशन
Again.
आहेत की सपोज जर एखादी अक्यूट केस आहे तर त्यामध्ये मॉडर्न मेडिसिन चांगलं करेल. पण
Big.
काही काळानंतर जर त्यांनी त्या केसेसमध्ये हेल्प घेतली आयुर्वेद आणि होमिओपॅथची, तर नक्कीच त्या पेशंटला चांगला इफेक्ट येऊ शकतो. फिजिओथेरपी तर आपल्याला सगळ्यांना वेल नोन आहे की
Yes, 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 yes.
त्या गोष्टींमध्ये परत एकदा मुवमेंट चांगली जर पेशंटची आपल्याला करायची असेल तर फिजिओथेरपी आपल्याला द्यायलाच लागते. त्याशिवाय
बिलकुल.
त्यांची
Yes,
कर्मचारी
yes.
आपण मदत घेतली तर नक्कीच फायदा होईल. थँक्यू सो मच सर फॉर युअर डिटेल एक्सप्लेनेशन.
इवन एक उदाहरण आता लक्षात आलं माझ्या. जस्ट इथं आता सांगून टाकतो. दिल्लीमध्ये मेदांत हॉस्पिटल आहे. त्या ठिकाणी इंटिग्रेटिव्ह मेडिसिनचं सेंटर आहे. आणि तिथे इवन सेरेब्रोव्हास्क्युलर ऍक्सिडेंट आहे, न्यूरोसर्जरी झाल्यानंतर आफ्टर सर्जिकल ज्या सगळ्या गोष्टी सोपस्कार संपल्यानंतर आयुर्वेदाच्या ट्रीटमेंट ते नंतर देतात. मी स्वतः पाहिलेलं आहे, माझे सिनियर तिथे काम करतात. म्हणजे माहिती असावं, रोबोटिक सर्जरी झाल्यानंतर सुद्धा छोट्या छोट्या ज्या प्रोसिजर्स इंडिकेट होऊ शकतात त्या केसमध्ये चालू शकतात. अशा आयुर्वेदिक ट्रीटमेंट्स, मेन पंचकर्म सोडून छोटे छोटे ज्या ट्रीटमेंट्स आहेत, तर त्या ट्रीटमेंट्स केस वाईज आपल्याला देता येतात. आणि आपण इव्हन मी माझ्या छोट्याशा प्रॅक्टिसमध्ये, छोट्याशा अनुभवामध्ये मी त्या वापरलेल्या पण आहेत. तर इथे वेळेचा आणि बाकीच्या गोष्टींचा थोडासा विषय होता, मग मला जास्त त्याच्यावर फोकस नाही करता आलेलं. परंतु आपले सरांचं काय म्हणलात नाव? आपले जे सर
डॉक्टर जितेंद्र.
हा, सरांनी खूप चांगल्या पद्धतीनं इथे म्हणजे एक वायवा पण घेतली आणि सगळ्यांना एक चांगल्या पद्धतीचं एक
डिटेल्समध्ये त्यांनी
डिस्कशन
आपल्याला
उपलब्ध करून दिलं.
कशी
त्याबद्दल
घ्यायची.
त्यांचं पण धन्यवाद व्यक्त
बरोबर.
करतो मी. आणि मला वाटतं तर
यानंतर
धन्यवाद. थँक्यू. नमस्कार.
आहेत सर. आपल्या सोबत राहा एक 5 मिनिट आणखी. डॉक्टर
बरं.
जितेंद्र कोडीलकर यांनी आपल्याला मॉडर्न मेडिसिन विषयी आपल्याला सगळा अप्रोच व्यवस्थित सांगितलेला आहे. यानंतर डॉक्टर नारायण जाधव यांनी आयुर्वेदानुसार चिकित्सा एक्सप्लेन केलेली आहे. त्यानंतर डॉक्टर पुष्कर बाविस्कर यांना मी इन्व्हाइट करते.
Yes.
ते वेल नोन होमिओपॅथिक प्रॅक्टिशनर आहेत, फिजिशियन आहेत फ्रॉम पुणे, आणि महाराष्ट्रामध्ये इतरही ठिकाणी ते खूप चांगली होमिओपॅथची प्रॅक्टिस करतात. तर आपण त्यांच्याकडनं ऐकूया. सर प्लीज.
Thank you for inviting me on this platform, Dr. Karale ma'am. Can you make me host? मला PPT share करायचे.
कम्प्युटर डिपार्टमेंट. कम्प्युटर डिपार्टमेंट.
Yes, ma'am.
Please make host to Advocate Prachi Joshi. प्राची जोशी, ऍडव्होकेट प्राची जोशी जे आहेत, तर
Okay, ma'am. Okay.
होस्ट करा प्लीज.
मॅडम एक्सक्यूज मी, मला एक थोडस एक इमर्जन्सी आहे, तर कॅन थँक्यू एव्हरीवन. थँक्यू मॅडम फॉर इन्व्हाइटिंग मी फॉर दिस मीटिंग, आणि इट वॉज व्हेरी वंडरफुल टू लिसन टू आयुर्वेदिक मेडिसिन सर. आम्ही भरपूर गोष्टी शिकलो तुमच्याकडनं, आणि आता इंटिग्रेटेड अप्रोच आम्ही पण वापरू. So I'm very thankful for everyone. I'm thankful to MHS. Thank you, madam.
Yes.
मला थोडंसं एक इमर्जन्सी होतं, तर मी मीटिंग लेफ्ट करतो.
या थँक्यू.
थँक्यू.
Yeah, sir.
डेस्कटॉपवर माझी फाईल आहे, मी शेअर कशी करू, मला गाईड करू शकेल का कोणी?
तिथे एक ग्रीन टॅब आहे सर शेअरचा,
शेअर केला. हा, त्याच्यानंतर
करा.
हा
पीपीटी ओपन आहे तुमच्या लॅपटॉप मध्ये?
हो ओपन आहे.
हा ओपन आहे. मग शेअर टॅब केल्यानंतर त्याच्यामध्ये जिथे पीपीटी दिसेल तो टॅब ओपन करा.
मॅम मी माझं शेअरिंग बंद करू का?
येस प्लीज. होतंय सर?
एकच मिनिट. येस, राईट.
सर आम्हाला दिसत नाही अजून. परत एकदा शेअर टॅब वर क्लिक करा. शेअर जी ग्रीन.
हो,
हा,
त्याच्यानंतर
आता तुम्हाला तुमची पीपीटी दिसेल स्क्रीन वरती, त्याला क्लिक करा ज्या ठिकाणी पीपीटी दिसेल तिथे. येस सर. ओके. येस.
So basically, I would like to start by thanking Dr. Karale ma'am for inviting me on this platform. And we'll start with this topic immediately because of natural time constraints. Just a minute.
सर वर एकदम वरती फुल स्क्रीनचा ऑप्शन.
Yes. So we won't go to the definition. It is amply been said, and we all know it's a cerebrovascular accident, which is due to a focal neurological deficit. A focal neurological deficit which is attributable to a vascular cause. Thus, we see that the definition of CVA is purely clinical, and we have seen the examinations and all the details. So we just rush through the slides. So these are the causes I have put down: cardioembolic stroke, the paradoxical embolization, enlargements, artery to artery embolic stroke, etc. So I won't go into the details. We all know this, or we can go through the textbook. I would straight come away to homeopathic approach. So allow me to reorient you from allopathic and Ayurvedic perspectives to this homeopathic perspective. The only difference that you have to know as treating physicians, treating homeopathic physicians in any case, is when you see a case, you have to select symptoms which are away from pathology. That is nosological diagnosis. So for example, the symptoms that help you in diagnosing stroke may not help you in selecting a homeopathic remedy. So the symptoms, the patterns, associated symptoms or causative factors which are prior to the disease, here stroke, will help you in selection of homeopathic remedies. So trying to find unusual symptoms is a key for homeopathic remedy selection. That is what I mean to say. So we will go to some examples. For example, if you see, this is a very well-known remedy in homeopathy. It's called arnica. Many of the non-homeopaths also know this remedy as a trauma remedy. So usually this remedy is useful in left-sided strokes. The characteristic symptom, as I told you, is the patient answers your questions. When you ask anything to the patient answers your question and falls back in stupor. That is, he just falls back in comatose state again. You have to arouse the patient again, ask the question, he answers, he falls back. That is a characteristic arnica symptom. Further symptom which classifies arnica is the head of the patient is hot and the extremities, that especially the leg, is colder. So that is a symptom which will help you select arnica in stroke cases. Basically, it is useful in both thrombotic and hemorrhagic strokes. As I told you, causative factors, the preceding factors which caused the stroke in a particular patient are important in homeopathic remedy selection. For arnica, the causatives are trauma or bad news. So any mental shock or a head injury which might have led to stroke, arnica can be selected. The second famous drug of homeopathy which is useful in stroke cases is opium. So the characteristic of opium, two things that every homeopath remembers and searches for is obtunded sensorium, that is a clouded sensorium. The patient is unable to answer properly, and you touch the forehead of the patient, there is a warm sweat on the forehead. So these two symptoms characterize the drug opium in any stroke case. Further symptoms are the patient has a red face and a noisy respiration. So naturally, opium will be useful from this information in large cortical strokes, brainstem strokes, malignant cortical strokes. When you examine the pupils, the patient has constricted pupils. Eyes are half open. So we all know half open eyes is rather a feature of encephalopathy rather than stroke. But you can find this half open eyes if patient needs opium as a homeopathic remedy in stroke cases. The third remedy that I would like to talk is gelsemium. Although it's not a very classical stroke remedy, it has a very classical symptom mentioned in our Materia Medica. The symptom is headaches are ameliorated after profuse urination. Now, this symptom is akin to when we use mannitol in raised intracranial tensions. What we usually expect is a diuresis by virtue of which the intracranial pressure goes down. So this is an indication for gelsemium. So basically in stroke cases, as discussed earlier, when the penumbra is formed, the intracranial tension naturally rises. So this drug helps to reduce the intracranial tension. It can be used in isolation or along with any indicated homeopathic remedy to bring down the intracranial pressure. What are the indications homeopathically of a gelsemium patient? So associated indications will be bradycardia and dilated pupils. So this also is a remedy which can be considered in large cortical or brainstem strokes. This remedy, causticum, almost every homeopath knows this remedy. So if you utter paralysis in front of any homeopath, the first medicine that goes into the brain of a homeopath will be causticum. This is a sheet anchor in post-stroke symptoms. So basically it's a remedy which is not useful in acute stroke symptoms, but after the patient has been settled by all the other measures and the remnant neurological symptoms remain. So basically it's a remedy for paralytic symptoms. It has general paralysis as well as paralysis of single parts. So it is basically a remedy which is associated with bladder and bowel dysfunctions. So you have incontinence, you have retention, etc. So symptoms which are associated with stroke commonly seen, bladder bowel dysfunctions. So it's a purely chronic remedy, useful even years after the patient presents to you with symptoms of remnant stroke. So this is how you approach a particular case homeopathically. Whenever a patient comes to you, you try to find out either causative factor, that is what led the patient to the stroke episode. It can be a mental factor, it can be a physical factor. And you try to find out 2 or 3 symptoms which indicate that particular remedy. These are, in homeopathic terms, these are known as PQRS symptoms, that is peculiar symptoms, which are unusual to be seen in that particular pathology. So the golden basic thumb rule for any homeopath to remember is farther away from the pathology the symptom, better symptom for homeopathic selection. That is how it goes. But we all know that this type of symptoms are not commonly seen. We may not always get that particular symptom, which is unusual, not related to pathology, and will help in homeopathic remedy selection. All those who practice homeopathy commonly see that this is not always possible. So if in such cases, we encounter such cases where we get only common pathological symptoms, the diagnosis and the patient is in front of you. So how do we go about? So these are certain short tips that I have put up. For example, if you have a patient with Wernicke's aphasia, So what does Wernicke's aphasia mean is the patient can speak fluently, but unable to understand what he is speaking or what the person in front of you is speaking. This symptom is classically seen in homeopathic remedy known as elapsed score. So elapsed score is a remedy classically, pathologically indicated in Wernicke's aphasia if you don't get the classical symptoms. Likewise, if you have a patient with Broca's aphasia, that is what is called as an expressive aphasia, where the patient understands whatever is being said, but difficult to articulate, is unable to speak out words. That is the time when you have a remedy called Bothrops lanceolatus, which you can prescribe pathologically. This is also a remedy which is used for amaurosis fugax, or what we call as transient monocular blindness. So this is a classical remedy for that. Further, there are certain observations or certain signs which can help in homeopathic remedy selection. So if you are examining the patient, there is no characteristic symptom, you're not able to come to a pathological diagnosis homeopathy wise. So if you examine and if you see, these are just clues, of course. If you see that the paralyzed part is cold, the remedy naturally that can be selected is Dulcamara. And on the contrary, if you see that the paralyzed part is hot to touch, the remedy that is selected will be Alumina. Likewise, there are symptoms which are encountered after stroke. Most commonly, we have amnesia after stroke. And these are two classical remedies which are very useful post-stroke amnesia. The remedies are Plumbum Met and Alumina. So this is how, in any case of a stroke, we approach homeopathically. To review in short, the first and foremost thing is causative factor. The second in line is any symptom which is away from the pathology. That is a PQRS symptom, which is peculiar and queer. That is unexplainable by pathology. Third is pathological prescription. If you are unable to go to any remedy with characteristic symptom, we try to find out what the pathology is and try to match those symptoms with pathogenesis mentioned in homeopathic remedy. And fourth in row is examination, wherein you touch the patient, feel the patient, and see if there is any unusual sign which is present, which can help to select the remedy. So they say never be the first or the last to incorporate a new idea into your practice. But these tips which I have given you, these have come from years of practice of homeopathic stalwarts and my teachers, which I have tried to given you. It was a short presentation owing to a very short time. I'm sorry for the short presentation, and thank you once again for a patient hearing. And thank you, Dr. Karale Madam, for giving me this opportunity to present my views on this platform. Thank you very much.
Sir, thank you so much for short and sweet and very important tips for our students. I hope it will be useful in their practice also. Thank you, sir. So we will end this meeting now. Thanks to Dr. Sachi for very nice and detailed presentation and surprise viva. Then thanks to Dr. Jitendra Kodilkar for detailed explanation how to take a case and how to diagnose and how to treat, how to manage that case. Thank you so much, sir. Then Dr. Narayan Jadhav, from his busy schedule, he gave us a time. Thank you so much, sir. Then Dr. Pushkar Bhaviskar, sir, very short and sweet and very important discussion about homeopathic perspective regarding cerebral artery infarct. Thank you. And thanks to all participants, my dear student. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.